Hello. Yeah, doctor. Hello, can you hear? Dr. Radhika, are you there? Hello. Good afternoon, sir. JC sir, good afternoon.
Good afternoon, Priya madam. How are you?
Fine, sir.
So, a lot of confusion, huh?
They have joined, but Shweta, please make them panelists, no? Good afternoon, Dr. Arpita ma'am. Can you hear me? Can't hear? Sir, JC sir, you can hear me, right?
I can hear you very well.
Then there must be some audio issue from your side, Dr. Arpita. You can log off and log in again.
Yeah, Dr. Priya, we can hear you, no problem.
Okay, sir. No, Dr. Arpita is unable to.
Yeah. I can
you are fine.
now.
Okay.
Hi,
Can you
Dr.
please share
Shivani.
your slides, ma'am, just to check once.
Yeah, we all have different presentations of ours on our laptops.
Okay, each one of you can do separately.
Yes,
No,
yes.
that's better also.
Yes.
Yeah.
So can I tell you the flow of how we'll be going? Because after Radha ma'am, she's going to hand it over to me.
Okay.
As Jitendra sir said, then I'll carry forward the
No
other
problem. No
presentations.
Yeah.
So you will
You can
mute.
introduce the next speakers from your
Yes,
side that you
yes.
can, anybody
And
can.
at the end, when we are done, I'll hand it over back to you, Dr. Priya.
Yeah, after all even the PG presentations.
Yes.
Yeah.
Yeah.
Okay.
Okay. Thank you.
Yeah, welcome, Dr. Yashwant, sir.
Yeah.
You can just share your slides and check. No audio, no? Any video you have?
We have videos in our case.
Yeah,
And
there
then
it is, they
please
have
check the videos because they
Yes,
should
we
not-
will. Radhika, she's telling you to share the screen and just
Radha
check the
ma'am, good
videos.
afternoon. Welcome. I'm Dr. Priya, National Coordinator. Dr. Savita, welcome.
Thank you so much, ma'am.
Hi, Dr. Priya. Sorry, I was on mute at that time. Dr. Radha.
Okay, ma'am. Okay.
Let me see over here.
Check whether the videos are working. She wants us to do that. Radhika, videos.
Because if there are any issues, we can send
Yes,
the
we can
slides to
fix
the
it up
DI.
right away. Correct. Just go, yeah. Do that. Click. Yeah, perfect. It's
Yeah.
working. Go for the next. We have 4-5 videos. Yeah.
Okay.
Go. Yes, perfect. Working. Next one. Second one. Do it. Not happening? Oh. Do the third one. Do the third one. Actually, she's going to switch her laptop. So on the other laptop, it's all working. But Radhika, we
Okay.
need to check it. Then check from. Yeah, you will need to check from that laptop, beta. Okay. Next. The videos are working, Dr. Priya.
Yes.
And I just wanted
Chief
to ask.
guest ma'am has joined, Jayashree ma'am.
No, she'll just.
Ma'am is there.
we'll-
Ma'am is there.
Okay. Dr. Priya, you will be muting, unmuting us, or we have all of us have our own controls?
You have your own control. No.
Perfect.
Jayashree ma'am, namaste. Welcome, ma'am.
Thank
I'm
you.
Dr. Priya here.
Yeah, hi.
You can send this attendee link to any of your faculty or any others who can join for the discussion.
We have sent the viewers link to many of them.
Okay.
Dr. Priya,
Yeah.
so you all will be starting, and then Dr. Kulkarni will introduce Jayashree ma'am.
Atul
Follow-
sir is not joining, so
Oh.
Dr. Parmanand will introduce.
Okay, so
Okay.
he'll introduce Jayashree ma'am, followed by Dr. Gawane introducing Radha ma'am, correct?
Yeah. Yeah.
Then Radha ma'am giving it over to
Yeah.
me.
Yeah.
I do the
You
proceedings till
can
the
do the
case,
rest of the.
and then I give it to you back.
Yeah.
And then somebody, Dr. Jog is talking.
Yeah.
Uh,
Yeah. In the last.
Perfect. And we keep to time, right?
Yeah. Please do that.
Yeah. So you also feel free.
If it
to
is
tell
going
in
out,
between.
I mean, if it's taking too much time, I'll message
Yes,
you.
please. Yes, please. Yes, please. Thank you.
रीना मॅडम सरांचं चालू असताना थोडंसं तुम्हाला बाजूला सरकावं लागेल. तुम्ही दिसताय स्क्रीन मध्ये.
Good afternoon,
Good afternoon,
madam.
Jalil sir. Welcome.
Good afternoon, all.
Good afternoon, sir.
Good afternoon, Dr. Priya. Good
Welcome,
afternoon,
ma'am. Good
Dr.
afternoon.
Jalil.
Welcome.
Thank you.
Good afternoon, Arpita. Everyone joined?
Hello,
Jai
hello.
Shri
Yes,
ma'am.
sir. Yes, sir. At
Yeah,
our end, we
all
are
are
all
there.
in.
All are
We
there.
are all in at our end.
Hello, sir.
Yeah.
Shweta, please make all attendees as panelists. No, Upendra sir has joined. And Shweta? Mamta ma'am is also there. Please promote. Parmanand sir, welcome. Good afternoon. Good afternoon, Upendra sir. Thank you so much for joining.
Good afternoon. ये तो हमारे घर का मामला है. So have to be there.
Hello, Dr. Upendra.
Good afternoon, everybody.
Good
Dr. Radha
afternoon.
madam. Jai Shri, hi. Arpita.
Hi. Hi,
Shwant,
sir.
hi.
Hi.
Yeah.
घर वापसी आपके लिए.
कहीं गए ही नहीं थे तो घर में ही तो है.
वो तो है.
We belong to that era where first MBBS to end everything at Sion only.
True.
Shall we start, sir? Sir will be joining. Basav sir will join.
Yeah, please start, please.
Yes, yeah. Good afternoon, all. A very warm welcome for our 40th episode of Academics with Institution. We are back with a legendary institution from West Zone. It's Lokamanya Tilak Municipal Medical College and General Hospital and this Sion Hospital. Many of us are very much familiar with the training which goes on in Sion Hospital. So all are eagerly waiting for this episode. Warm welcome to all of you. A hearty welcome to our President, Dr. G. Basavaraja sir, who will be joining in a short while. Welcome our immediate past President, Dr. Upendra Kinjwadekar sir. Thank you so much for joining in. And welcome our HSG, Dr. Yogesh Parikh sir, and National Treasurer, Dr. Atanu sir. And our President-elect, Dr. Vasant Kalatkar sir, who might join in a short while. A hearty welcome to our Vice President, Dr. Satish Sharma sir, who is joined, and welcome our Joint Secretary, Liaison Dr. Parmanand sir, and our West Zone Coordinator, Dr. Jitendra sir. Welcome to our GV Basavaraj sir. Thank you so much for joining in. And hearty welcome to our Chief Guest, Dr. Jayashree ma'am. Thank you so much for accepting to be here. Welcome our Chairperson, Dr. Radha ma'am, who is also the HOD of LT Lokamanya Tilak College, and all the faculty, Dr. Yashwant, Dr. Arpita, Dr. Savita, and the postgraduates. Welcome team IAP 2024. I request our National President, Dr. G. Basavaraj sir, for your opening remarks.
Thank you so much, Dr. Priya.
Academics through the institution is one of the flagship program of the year 2024. This is where many of the faculties, students, and practicing pediatricians all are looking for this very important program. And this program, which is not only it is created inspiration to the many of the postgraduate and as well as the faculties and institutions, where a lot of them has been benefited out of these programs, where the viewership has been almost in a excellent across the India. And today, which is to be LLM3, which is in a very old college and which is been always in a contributed immensely to the Indian Academy of Pediatrics with the presence of our chief guest of the today, Jayashree Madam. Welcome, Jayashree Madam. Along with Radha Madam, who she is going to be the chairperson, and the faculties of the college who has been in providing a lot of input to our Indian Academy of Pediatrics, Dr. Yashwantji, Dr. Arpita, Dr. Savita, and all the postgraduates. This has been well conceptualized under the guidance of Dr. Jagdish Chinnappa sir, our chief advisor. Dr. Priya has carried out in all the programs so far, and with of course our office, which is always supportive, led by Dr. President-elect Dr. Vasant Kalatkar, our immediate past president, Dr. Upendraji, Parmanand Anandkar, and our West Zone Vice President, Dr. Atulji, was been doing a great work in the behind the scene with the West Zone Coordinator, Dr. Jitendra Gawane. So all the office bearers and vice presidents who has been contributing immensely within a South Zone Vice President, Dr. Singarvelu, East Zone Vice President, Dr. Santanudev, and Central Zone, Dr. Ajay Srivatsavji, and the North Zone, Satish Sharmaji, and all the EB members who has been helping across with our dynamic secretary, Dr. Yogesh Parikh, in spite of traveling, he has been joined, and Dr. Atanu Bhadraji, our national treasurer. So I'm sure this will make a big difference with the always a supportive, like our Mamta Manglani madam is also been there. So I recognize the presence of Professor Mamta Manglani madam. Best wishes for the today's program. Looking forward to listening to the today's deliberation. Over to you, and I recognize the presence of Vijay Avale sir, our past president of Indian Academy of Pediatrics.
Yes, sir.
Over to you, Priya.
Hearty welcome to our past president, respected Vijay Avale sir. Thanks to Mamta Manglani ma'am for joining. I now request our immediate past president, Dr. Upendra Kinjwadekar sir, for your remarks.
Yeah, very good afternoon all. Dr. Basavaraj, Dr. Jayashree, Dr. Radha, Dr. Priya, Dr. Jagdish, and all my dear colleagues of current and past EBOBs. Of course, it's a special feeling, special honor, all of us. When it comes to your alma mater, you have specially privileged and of course very, very, very happy. So Priya, thank you so much for conducting this academic with institutions. And I'm sure this gives an opportunity to the past students to get connected again to their alma mater. And of course, every institution has something unique under its belt. And it's a time to showcase that talent, and people look across the country know. So this is for what SIAN is famous for, and this is what is known. So I'm very happy and proud. And you would see in coming 1 hour, the deliberations that would take place, that what is so special about SIAN, the kind of training all of us underwent there. And for IIP, it is mighty pleasure to let me share with you that from Dr. M.R. Lokeshwar, Dr. Bakul Parekh, Dr. Nitin Shah, Dr. Vijay Evle, myself, and of course Rohit for some time. So all of us have been past students and probably the only institute which has given the maximum number of IIP presidents. So 3 cheers for my alma mater, LTMMC, and a great institute. So let's have wonderful deliberations. Thank you so much for choosing our institute in this program. Thank you.
Thank you. Thank you so much, sir. Not only academics, but they make great leaders. That's what you are re-emphasizing. Thank you so much, sir. I now request our past president, Dr. Vijay Avale, sir, for your remarks. Share your thoughts.
Yeah. First of all, very good afternoon. Compliments to the Central IIP for hosting such unique kind of program where institutions are recognized, and it gives an opportunity for the students from the institution to interact and be present on such platform, and to let the IIP fraternity know what the institution has done and what it is all about. And as Upendra said, SIAN Hospital is our home. I mean, it's a very candid I would say confession that what I am today is because of Sion Hospital and Indian Academy of Pediatrics. And I still recall days when, I mean, we had a unique fate of having a very small batch of only 60 students. And we knew each other so well that it felt like a second home. It was a family. And it's wonderful to be here, connecting with our uh, old seniors and teachers from Sion Hospital. It's a moment of pride for all of us Sionites. Sion Hospital is very popular as Sion Hospital, though the name is Lokmanya Tilak Municipal General Hospital, popularly known as Sion Hospital. And we Sionites are really proud of our alma mater. So I would turn it over to the organizers to conduct the session, and it's a wonderful moment and it's really pleasure, and the heart fills with pride when you see your alma mater people, being on such a platform. So with these words, I thank once again IIP for talking about Sion Hospital today.
Thank you. Thank you so much, sir, for encouraging all of us by your presence. I now request our HSG, Dr. Yogesh Parikh, sir, for your words. Unmute, sir. Unmute.
Yeah. So good afternoon, all the respected seniors and dear friends. I joined late. Sorry for that. I'm traveling, and warm welcome to our President, Dr. Basavaraj sir, Dr. Vasan Khalatkar, Dr. Upendra, Dr. Vijay sir, and all the past presidents who have the Sion alumni. I was, and I am very proudly say that I will be was there as an examiner several times with Dr. Radha madam and Dr. Arpita and Dr. Yashwan sir and everywhere. So I am also feeling very proud moment for today's. This is a great institute, Lokmanya Tilak Medical College and the Sion Hospital. So I think this is the 40th episode and very popular program across the country. The academics with the institute under the guidance of Dr. Jagdish Sinnappa sir and our Vice President, Dr. Atul Kulkarni, selected this institute, the premier institute, to present today's program. So I think Dr. Savita madam and Dr. Radhika and Dr. Avanti will joins today for the great deliberation of today's program. So thank you very much. Also, Dr. Jitendra, our academics coordinator from the West Zone. So thank you very much, and please best wishes for the great success of today's program.
Thank you. Thank you. Thank you so much, sir. I now request Dr. Parmanand sir, Joint Secretary of IAP, to introduce our respected chief guest, ma'am, Dr. Jayashree ma'am. Over to you, sir.
Good afternoon. It's a nice moment to be here, and it's nice to see this is one of the, as Dr. Bhattaraj says, it's a flagship program of the IAP. It's really helping all the students across India to learn from far teachers, and the knowledge is getting shared with everyone. And with this, I had to introduce today's chief guest, none other than Dr. Jayashree Monkar. We all know she is a passionate teacher. She is she has one of the pioneer members in developing the Department of Neonatology and Science, which has produced multiple very excellent neonatology across the world. She has retired as a dean and professor of the head of neonatology department of Lokmanya Tilak Sion Hospital, Sion. And after she retired, she still continues to her great work by affiliating her as a trustee of Society of Nutritional and Education and Health Action for Women and Children. And she is also the accreditation. She is the chair of the NNF accreditation committee. She's also the past member of technical advisor for multiple committees like Department of Biotechnology, as well as the advisory committee of Human Well Banking. She was also the past president of NNF Mumbai. She has been awarded various awards, like a Gem Spirit Award as an author in 1990 and 1992. She has also received a Lifetime Achievement Award from Mumbai Breastfeeding Promotional Committee. She has been awarded as a Rotary for her excellent services in 2015. Also, she had organized multiple workshops and conferences which will help the students to learn many things in the field of neonatology by programs like neonatal resuscitation, ventilation, breastfeeding, and milk banking. She has also organized a national conference of NNF. I request Vijayashri Monkar Madam to share her view. Thank you once again. I welcome everyone for this wonderful learning.
Thank you so much, Dr. Parmanan, and very good afternoon to everyone. It's really a pleasure to be part of today's program. And for this, I'd like to thank the IIP as well as my colleague and friend, Dr. Radha Gildial, who's the professor and head of pediatrics at Sion Hospital, for inviting me to be here. So at the outset, I'd like to really congratulate the entire IIP team, particularly the current, who have thought of having this flagship program. And the fact that it's in its 40th episode means that it really rocks volumes, speaks great volumes for its popularity. And I think it's really a wonderful idea because, when you have large teaching institutions, especially when they're attached to public hospitals, they're bound to have a huge, caseload and interesting cases which can be well worked up and evidence-based management. So when these are given an opportunity like your DIAP platform to be showcased, to the PGs, and not only the PGs, but even to the pediatricians across our country, it becomes a learning point for them, and also showcasing the effort that has been put in by the members of the department. So really, compliments to DIAP for coming up with this idea. Now, to talk briefly about our institution, the Lokmanya Tilak Municipal Medical College and General Hospital. It's called popularly known as Sion Hospital. It was established in 1947, and we deal with the poorer strata of society, and we have 1,900 beds. Every year, virtually, there are about 20 lakh footfalls to the outpatient department, which may be, both the new as well as the old cases, and about 80,000 plus admissions to the hospital each year. So that's the magnitude of work that we have. Now, Sion House, talking of the medical college, the medical college was established in 1964. We have all the broad specialties. We have about 12 super specialties, of which neonatology, which I headed previously and now working as Professor Emeritus, are one of them. We have Sion Hospital has many firsts to its credit. And among them, first, I would like to talk very briefly that I say that the Human Milk Bank, which was established way back in 1989, first not only in India but in Asia, which is associated with our department. And today we are recognized as a zonal reference center since 2019. So, and the milk bank is really going strong, providing human services to the tiny preterm babies and improving survivals. Now, besides this, of course, the first skin bank in the country, then the first cadaveric renal transplant in the city of Mumbai, the first learning disability clinic. All these are some of the firsts for Sion Hospital. Now, talking of our pediatric department, as a dean, I think means I always felt that the most star and the best department was pediatrics. Simply for the reason that they are so perfect and so correct in whatever is asked of them. So whenever anything had to be submitted, be it a submission for say the what was then called the MCI, now the NMC, and whatever documents had to be submitted, theirs would be done promptly within the given stipulated time and most appropriately done. Of course, besides that, the Department of Pediatrics is like a 5-star department because they have an excellent, robust teaching program, teaching and training for the postgraduate students. But what makes this department so special is that it has nurtured subspecialties. And this has been a tradition which has come down from our very first teacher, and that is Dr. Vasant Athavale. A doyen in the field of pediatrics, a wonderful person who is, whose legacy still continues today. So today, pediatrics has 9 subspecialties, and that help each faculty member in the department is encouraged to, participate in one of these subspecialties, and this results in their own personal growth and in improvement in quality of care. So kudos to the Department of Pediatrics, kudos to all the past heads of departments, Dr. Athavale, everyone. We have one famous head here, Dr. Mamta Manglani. I would also talk of Dr. Meenakshi Mehta, Dr. Madhuri Kulkarni, Mamta Chandra, as I call her. And of course, the current head of department, Dr. Radha, along with her team of pediatrics who have consolidated what has been done and have further expanded and have set the bar higher for the department to grow even further. So I'd like to end by saying that they've chosen two interesting subspecialty cases. I'm sure everyone is going to be glued to their seats and they're going to find it very interesting. Thank you very much for the patient listening.
Thank you. Thank you so much, ma'am, for sharing your thoughts about the Sion Hospital. It means a lot for accepting an invitation to be as chief guest for today's session. Thank you. Thank you so much, ma'am. I welcome our President-elect, Dr. Vasant Kalatkar, sir. Yes, Vasant, sir, hearty welcome to you. Request for a few words from you.
Thank you, Priya, for calling me. I don't want to disturb. I welcome you all. And thank you, Jaisri madam. Really, and thanks. So good words about the pediatric department. And really, your team is doing really great job for this. So thank you once again for appreciating pediatric work. And the work will go on. This same team and this program will go on for next year during my tenure. Thank you, Professor Raja, for starting and all team. Thank you.
Thank you. Thank you so much, sir. It's really overwhelming to see so many past presidents, president-elect, all. We have almost 5 past presidents here, and we have almost full OB presence. Welcome, Dr. Atanu Badra, sir, also. I now request our West Zone Coordinator, Dr. Jitendra Gawane, to introduce our respected chairperson, ma'am, Dr. Radha Gildial.
Yeah, good afternoon, everyone. Respected teachers. Today is a moment where I want to re-talk about the words by Upendra sir, that maximum number of IAP presidents are given to India by this department from Sion, right from Lokeshwar sir up to Upendra sir. And being in Mumbai, although I am not from this institute and I'm from JJ, the beauty of Mumbai is that we get to learn from each of the medical colleges, great mentors, and my maximum mentors are from Sion Hospital, right from Suhas Prabhu sir, Nitin Shah sir, Yevle sir, Mamta Manglani ma'am, Upendra sir. So thank you for imbibing the good spirit in me, and I'm fortunate to learn from every one of you. So today we are having a academic with institute from this great institute, and to lead this institute also is so much fortunate, and it's a responsible job. So today we are welcoming our ma'am is a professor at LTMC Sion Hospital. Madam is a chairperson of POSH committee of LTMC Hospital. She's a chairperson of state AEFI subcommittee. She's a national trainer of lactation management and IMNCI trainer. She's an accessor for national trainer for BFHI movement. Madam has almost more than 50 publications in national and international journals, and her work in IYCF and pediatric nephrology is very well known. So I welcome ma'am, and I hand over to you. Thank you, ma'am.
Good afternoon, everybody.
Priya,
sorry.
Yeah. So Priya, my friend is in pipeline. Yashwant is also here. So good prospects for Yashwant to come in national forum as a. We are behind him to come into IAP for a long time, and so let us hope that he listens to us. Welcome, ma'am. Sorry.
Yeah, hi. Thank you very much, and thank you IAP and DIAP for all the opportunities that you are giving. And I want to thank each one of you who has said such wonderful words. But as Dr. Mondkar madam said, it is only because of the foundation that has been laid by all the doyens associated with this department that we are in a position today to build on it further and take the legacy forwards. I'm having a little bit of a problem with my slides, so just give me 2 minutes. But in the meanwhile, I would like to say, so I speak on behalf of the department at LTMGH and LTMMC. To tell you a little bit about our department was established in 1959 with Dr. V.B. Athavale as the acting chief at that time. It was housed in 2 barracks with just 60 beds. And in 1967, the MD degree was recognized. Our first MD student was Dr. Prashant Moralwar. Today, we have 4 units, 160 beds, 15 postgraduate students joining us annually, and 9 pediatric subspecialty divisions. We are now affiliated to the Maharashtra University of Health Sciences. Our departmental activities focus on patient care, pediatric subspecialty divisions, structured UG and PG teaching programs. We focus on clinical skills and bedside teaching, both for the UGs as well as the PGs. We also run 5 pediatric fellowship programs affiliated to the Maharashtra University of Health Sciences and are actively involved in research and publications. In addition, we are involved in various community activities and social ventures as well. I would like to just tell you all about the 9 subspecialties that we have. Hematology, oncology, including bone marrow transplant, thalassemia daycare, HIV, gastroenterology, hepatology with endoscopy, pediatric neurology, neurodevelopment, epilepsy, and the LD clinic, pediatric cardiology, endocrinology, nephrology, the Nutrition Rehabilitation Research and Training Center, and respiratory services. The pediatric hematology oncology services were established in 1976. In 1988, Dr. M.R. Lokeshwar sir started the first thalassemia daycare center with just 4 beds. Today, we transfuse approximately 20 pediatric patients daily in this very center. In 2014, Dr. Mamta Manglani, who is one of the founder members of the oncology work that we do today, set up the state-of-the-art 20-bedded pediatric hematology oncology ward with 1 bone marrow transplant room. This was the first bone marrow transplant service in a public hospital in a city with minimum or no expense to the patient. To date, we have done 96 transplants and a success rate is approximately 86%. And the indications are both hematological as well as oncological conditions. We are in the process of expanding our bone marrow transplant services with additional rooms and a step-down section as well. We also run an after chemotherapy OPD, a post-BMT OPD, and taking on from Dr. Manglani's work, we have Dr. Sujata Sharma and Dr. Purvi Kadakia, who are in charge of this division now. The pediatric HIV clinic was established in 1998. In 2007, we became the regional pediatric ART center. But in 2011, again, under the leadership of Dr. Manglani, we were designated as the Pediatric Center of Excellence for HIV, one of the 7 in our country. We conduct video conferencing and telemedicine sessions and are linked to 92 centers across Maharashtra. Dr. Yashwant Gabale is in charge of this section. In 1990 was established the Diarrhea Training and Treatment Unit at our institute. The establishment of a division of gastroenterology, hepatology, and nutrition was in 2000. And in 2015, both endoscopy services started. Today, we have 3 endoscopes of our own, and we do both diagnostic and therapeutic scopies, and Dr. Prachi Karnik leads the team in that area. Nutritional Rehabilitation Research and Training. This was established in 2011 by Dr. Alka Jadhav, and we are now the nodal NRC center for the Municipal Corporation of Bombay. The team focuses on growth monitoring, early identification, management, and rehabilitation of malnourished children. Indigenously manufactured medical nutrition therapy, cups and sachets, as seen in the slide, are manufactured in the production unit attached to our NRC. The first clinic for certification of learning disability by the state of Maharashtra was in this very institution way back in 1996 by Dr. Madhuri Kulkarni. Today, we are seeing approximately, we screen about 4,000 children annually for LD with 40% certification. And Dr. Mona Gajre who is in charge of the division, is very ably supported by Dr. Arpita Adhikari and Dr. Nilesh Belsare. In 1998 was set up the Division of Neurology, Epilepsy and Developmental Pediatrics. And in 2013, we started Pediatric EEG services. Again, we have the machine and Dr. Arpita does our EEG certifications and reportings. We relaunched our pediatric palliative care services with a multidisciplinary team in place now. And we are looking at not just oncology patients, but a lot of footfalls from the non-oncology teams as well. We are also involved in grief counseling and bereavement support. And our aim is to improve the quality of life, not just for those with chronic illnesses, but also those with life-threatening and life-limiting conditions. Dr. Nikita Shah leads this team. Our PICU, we have an 11-bedded, well-equipped PICU, a state-of-the-art facility with everything possible for invasive and non-invasive monitoring. It's one of the heaviest PICUs with 100% occupancy. Dr. Masavkar, Sanjeevani Masavkar and Dr. Savita Khatse are our intensivists. Our hospital drains not just the suburbs and surrounding localities like Dharavi, Kurla, etc., but we are in fact the first major public tertiary care hospital as you enter Mumbai, be it from any direction. And that is what causes and we have so many footfalls because of that reason. In addition to all these, we have pediatric cardiology services with our own 2D echo machine. Dr. Sanjeevani Masavkar looks after that section. We have pediatric respiratory and nephrology by Sadhna Zope, and endocrinology services by Dr. Savita Khatse. So each one of our faculty members is involved in some pediatric subspecialty in addition to all the work that they put in general pediatrics as well. Our annual PG intake is 15, our UG intake is 200. In addition to 5 MUHS fellowships in pediatric hematology oncology, PICU, pediatric neurology, pediatric neurodevelopment, gastroenterology, hepatology, and nutrition, we are one of the 2 departments offering the FNB course in pediatric hemat onco in Maharashtra since May 2024. We also have the Ispagan Fellowship in pediatric gastrohepatology and nutrition. On our research, Dr. Masavkar will be telling us about it in a short while. We conduct multiple seminars, host CMEs, zonal rounds for the UG and PG quiz, annual CMEs in pediatric endocrinology, and the DAFPAL, which is our alumni association, and IBCLC trainings, to name just a few. Our faculty members are acknowledged authorities in their field of interest. They are much sought after examiners, and they also serve as inspectors for NMC and MUHS inspections, UG and PG. And they are guest speakers at the national level. Parent awareness programs celebrating festivals, counseling sessions, play-learn activities, yoga are just some of the things that we do to bring a little bit of cheer into the lives of our patients and their families. Hygiene kits are distributed to every patient who is admitted in our wards. Our journey ahead includes expansion of our pediatric hematology oncology services, our bone marrow transplant facilities, home care to be included in our pediatric palliative care services, encouraging research amongst postgraduates, not just restricted to their thesis, and starting an MUHS recognized fellowship or a certificate course in pediatric endocrinology, pediatric palliative care, pediatric nephrology, among others. Our vision is comprehensive holistic care for all, without boundaries, to cover both the haves and the have-nots. We do not want any patient to suffer or not have access to the optimal care possible because of financial issues. We all feel in our team that optimal healthcare is a basic fundamental right for every child. Parent awareness, counseling and communication with empathy, medical education and teaching, and working more on our research and publications. Our whole team lives by our values of integrity, We aim to be honest and ethical in all that we undertake and hold ourselves responsible and accountable for the well-being of our patients, their relatives, our students, and our team. We commit to ongoing research, academics, and practical upskilling to provide the best possible care for all our patients. A big thank you once again to Team DIAP for giving us this opportunity to showcase our department. Thank you so much. I now hand over to Dr. Arpita Adhikari to take the proceedings forward. Dr. Arpita is the Associate Professor in our department and a very integral and strong part of our pediatric neurology and neurodevelopment team. Over to you, Arpita.
Thank you so
Thank
much,
you so
ma'am.
much,
Before
ma'am.
Dr. Arpita takes over, would
Oh,
request
sure.
our Chief Advisor, Dr. Jagdish Chinnappa, sir, for your thoughts. You would have got many memories to share also. Over to you, sir.
No, I will come in at the end. I won't.
Later.
No.
Okay. Sure. Dr. Arpita, please take over.
Sure. Thank you so much, ma'am. I can say that, yes, I'm Associate Professor Pediatrics, but I would say I'm a true and a proud Scienite here. I complete 28 years in Science, beginning as an undergraduate, and it was so wonderful to hear those words about Science Hospital, my alma mater. And I can just say that this is because of the visionary head of the departments, the previous head of the departments that we had, all our seniors and colleagues. And now because of the true guidance, support and encouragement by our current head, Dr. Radha Gildial ma'am. So all the facilities, subspecialties that she had spoken about, all of us owe to her for leading us from the front, but giving the name to each one of us. So thank you, ma'am, for your wonderful overview. So now we move on to the next keynote address. And for the keynote address, I would like to invite Dr. Yashwant Gabale, sir. He is an additional professor in the Department of Pediatrics, and he is the program director for the Pediatric Center of Excellence for HIV. Over to you, sir.
Unmute Yashwant.
Yashwant, we are unable to hear you. Are you muted? Please unmute.
Yeah. So it is a very proud moment. Thank you, Dr. Arpita, to deliver the keynote address, especially on pediatric HIV, which I am right now heading this division. But I will like to go back to the journey. It is started in 1998. It is the brainchild of Dr. Mamta Manglani, madam. So this is the picture which was taken when the first pediatric HIV clinic was started, one of its kind in India. Dr. Nitin Shah sir and Madam Manglani, along with dermatologist and Anuma Borkar madam was there. So it was used to run every Wednesday, once a week. And I was a huge PG student that time, just joined in the Department of Pediatrics. And I was fortunate and I've seen the journey from 98 onwards till date. So as the cases were increasing, we have started the integrated clinic along with the medicine, gynecology, skin and optal. All used to sit together once in the afternoon, on Monday afternoon. And the cross reference were done at the same time. So the patient doesn't have to run from one OPD to other, because there were some cases which require some dermatological opinion, some require maybe gynec opinion or optal or chorioretinitis. So this all was under one roof. So, and then soon as the cases were started increasing, the epidemic was at the peaks, and NACO felt that the free ad should be given to the adult patients. So after much of this thing recognition, the pediatric formulation was also brought by the pharma people somewhere in the mid of the August 2005. So in August 2005, we started getting the free ART medication. Before that, it was very difficult for the patient to purchase the medication. I will just give an example, because I have seen patient who is weighing 10 kg who used to spend 2,000 rupees for that medications, because that time Duovir was available, that is the dual therapy was available. And with the NACO's initiative, this ART was freely provided to the patient, and many of the patients' lives were saved, because we have seen much of the mortality child were dying more of the tuberculosis or PCP pneumonia, and many of the children were dying before the 2 years of age. And depending upon the overload, in 2007, we are designated as regional pediatric ERT center, again in one of the 7 centers in India. And soon our patient load was more than 1,000, and then our center was recognized as Pediatric Center of Excellence for HIV care. Again, it is one of the 7 centers in India. Not just we are catered to the pediatric HIV, but another feather in the cap, which Dr. Mamta Manglani has initiated, and she initiated the first of its kind telemedicine services for pediatric HIV patient, and where we have a dedicated video counseling sessions, and we have now 2024, we have reached to around 92 centers, which Dr. Radha Madam has just mentioned. Now we are catering around 19 centers in Mumbai and around 72 centers across Maharashtra. So what we are doing at Center of Excellence? Why we are called Center of Excellence? Because we have dedicated counselors, which are providing the not only age-specific counseling, but as a family, as a unit, they are providing the counseling, and they are also focusing on the adolescent issues, and they are having separate sessions for them. I call Mitva sessions. They are conducted regularly. We have a dedicated nutrition support given by the BMC. We have a dedicated nutritionist, and she counsels the nutritional part of the patient, because we have seen a lot of the patient not only having anemia, but also the anemia of a nutritional cause. And if you give a proper diet, and we have seen the change in their morbidity and mortality. Of course, we are giving free ART treatment to all our patients referred to us, and we are also having free immunization services. Apart from routine immunization, we are providing them the other special vaccines, such as influenza vaccine, typhoid, chickenpox, or hepatitis A vaccines to our MSW department, free of cost to this patient. We are also doing all the comorbidity screening, because we are tertiary care and we have all the facilities, including CT, MRI facilities. Of course, telemedicine is one of the key factor, which when the patient is transferred to other centers in the Maharashtra, we are mentoring to telemedicine to them. And one of the key role, which is a PPTCT program, that is prevention of mother to child transmission, is one of the main impact factor. Madam Manglani always used to say that one day it's my dream that this center should be closed down, because there should be no pediatric HIV patient born with HIV status. So that is what prevention is always better than care. That means again emphasis here. And we are, of course, providing all the training offline and online. We have conducted more than 20 to 25 trainings here at our Sion Hospital and under the pediatric department. We are providing rehabitation support to all the patients. There are around 9 to 10 NGOs attached to us, to MDAX, and they are providing all this support to them. We are having a linkage support to the orphanage, because we are around 30 to 35% the children, either they are single orphan or double orphan. And the challenges being when the child is double orphan, because they are cared by the extended family. And we are also seeing some of the cases where abuse cases, and then we have to place these children in orphanages. We have a beautiful play area, a dedicated play area, where the patient, when he is in a waiting period, they can sit there, they can have some fun activities conducted by our counselors, and they don't feel that they have come to the hospital, and they are very happy to come to the center, because these children need to take the medication every monthly basis. We also have various recreation activities conducted for them. So these are the right hand side. I'll just highlight. We have started the center means enrolling the patient for free ART. So it has reached to 3,592 till date. And we have now active and alive on ART on 1,023. And the telemedicine services, we have provided around 6,777 tele sessions for the patients. And this is just bar diagram, which you can see in 2005, we started the free ART in mid-August, and slowly all patients were started enrolling. So there is a sudden surge in 2007. You can see there around 561 when your patients were, all the backlog has been converted, and they were enrolled, and then ART was started initiated to all the patients, and NACO has started free ART for all. ART to be given to all the children from 2019 onwards. So all the children are now on ART. Previously, there were some CD4 criteria, clinical staging were there. Now it is all removed. Any child or any adult is positive, ART should be started as per the NACO protocol. We are catering to children up to the 18 years, but still we have some children who are more than 18 years with their parents are enrolled, and slowly they are going to be phased out to the adult center. So this is just about the antiretroviral drugs we are providing to them. This is a slide that we have NRTIs, NNRTIs, PIs. All these drugs are provided free of cost to our children. And now the regimen has been shifted to the ALDTG, that is Abacavir, Lamivudine DTG started to children less than 20 kg, and between 20 to 30 kg we start Abacavir, Lamivudine, Dolutegravir. And once the child is more than 30 kg or about 10 years, the single pill is there, TLD. Again, thanks to the NACO that they have come out with a single drug formulation so that the pill burden is lower and the compliance and accessibility is also better in children. So as I said, that PPTCD service is very, very important. And the goal is to work towards the elimination of pediatric HIV and improve the maternal and newborn. And we have a very good teamwork with the OBGYN, neonatology, and the pediatrics. So we work together as a unit. And once the child is born, we categorize them as low-risk infants and high-risk infants. The low-risk infant is the one who is born to mothers with suppressed viral load, that is less than 1,000 copies per ml, and anytime after 30 weeks of pregnancy up to delivery, and the child can be initiated on syrup nevirapine. But if the mother is having HIV too, then the syrup zidovudine can be added, and duration of prophylaxis is from birth to the 6 weeks of age is given to them. If it is a high-risk infant who is born to a HIV positive mother whose viral load is not suppressed and she's not on ART, then we have dual options of nevirapine and zidovudine can be given together. Again, we have to look whether the mother is exclusive breastfeeding the child or child is on exclusive reflection feeding. If child is on exclusive reflection feeding, then the prophylaxis is given to 6 weeks. If child is on exclusive breastfeeding, then it is given up to 12 weeks of age. So again, it is not only that giving the ARV prophylaxis, but overall following everything in a child right from the development, immunization schedule, routine baby clinic, doing the early infant diagnosis, which we usually start at 6 weeks of age. And if the child is shown to be positive, we do the retesting. I will show you this algorithm. It's very complicated algorithm, but as per this algorithm, we proceed. If the child has 2 positive DNA PCR, the child is labeled as positive and the child is started on ART. So initially we had a lopinavir syrup, which was one of the main drug in the first line ART, but it was very bitter, and therefore the various parents also complained to us. Even we have tested this syrup; it was very, very bitter. And then we requested the NACO, and it was from the consensus they have come out with the pellets, and this pellets was one of the initiation of. It was a pilot study done by our PCOE, and it was found to be very acceptable for the patients. So we have difficult to treat and challenging patients which are referred to us. So that's why as a center of excellence, we have a PSASEP and DASEP. So PSASEP is Pediatric State AIDS Clinical Expert Panel, and DASEP is a District AIDS Clinician Expert Panel. So we have different committee members from right from medicine, gynec, psychiatry, and all other our doctors are there, nutritionists there, counselors are there. We sit together and decide the cases, whether the child needs to change from one line to the another line or any other further medication can be added, and there we decide and we give the advice. So this is just a rough about orphan data. That orphan children is also one of the big issues to us, and we are tackling them very successfully. So this is just about the telemedicine unit. I have given the Maharashtra map, and here is the Gondia, which is the farthest center linked to us. So if you can consider distance, it's around 1,008 kilometers. So person from Gondia want to come because many of the centers don't have pediatricians. And if they want any consultation, if they want to travel so long, spend money and spend daily wages, it was impossible for them to come. But with the ease of telemedicine, we can give their expertise advice, our expertise advice. We can educate the doctors there, counselors. We can do the e-mentoring, empowerment, and evaluation and excellence in care. So there are total 91 centers are now linked to us. So benefit of telemedicine is that it saves time and effort and money. It is very cost beneficial. So it forms a HIV care provider family. We can do regular monitoring and mentoring and evaluation and establish linkage with the rural and peripheral centers. And we have done 3 studies which Dr. Sanjeevani Masakar will talk upon that, and it was very impactful study. So we have this map, and it can you can see that it's almost all district we have television centers which are linked to us, and these are the video conference sessions, live sessions. This is just screenshot put up here as collage. So these are some of the group counseling sessions we are doing, where we not only give them positive thoughts, but we tell them to adhere to the treatment, because adherence is very, very important. Not only giving the medication, but how the child is taking the medication, whether it is on right time, because every 12 hourly, or if it is a once a tablet, the time has to be adhered to that. If it's not taking on time, the virus will have a chances of developing resistance to that. So we also provide nutrition evaluation and nutrition counseling to them. Positive living thoughts are given at every now and then, and social schemes is also implemented, including for the patients who are very poor. We have linkages with the NGOs, so that they are linked to the NGOs, and their education is also supported. We also do the vocational trainings for this adolescent children, and this is a mitva. We especially focus for the adolescent children, and we give them the career guidance and how to handle the peer pressure, because some of the adolescent children, once they know they are positive, they have negative feeling towards life, and they have suicidal tendencies. Sometimes they have drug abuse. So that we have to also tell them that how to have drug abuse abstinence. We have to properly educate them about the sex education. So this is the one of the, we regularly conduct the nutrition activity. This is one of the Poshan Ma Abhiyan activity was conducted by our nutritionist. Throughout the month, we have various sessions. So she is explaining about the food pyramid to the kids. So our was one of the first to start pediatric HIV palliative care in the country, along with the collaboration with the UK Help the Hospice, Indian Association of Child Palliative Care, and Tata Memorial Hospital. And here we are conducting. This is our old center. Now we have upgraded. So we also had a Ankur support group, which is again every monthly basis we are having this Ankur support group for the PPT city parents. So there are various visitors who visited our center. So one of the Mir Mankat from CFI has visited to us. And again, you can see this is a collage picture put up here. Princess of Norway has visited. Southeast Asian delegates. Aishwarya Bachchan visited on 1st of December. UNICEF Ambassador Sharmila Thakur also visited our center. Visitors from UNICEF. And recently we have PEPFAR team from USA to visit our center. Not only providing the drugs is our thing, but we also engage in various social activities. We celebrate almost all festivals. You can see our HOD posing with Santa, and myself being there in the, our children perform some of the dance activities. We have also had World AIDS celebration with the patients, and we conduct various activities and seminars for the patient and doctors. And we have our another NGO, Make a Wish, who fulfills wishes of all the HIV positive children. So this child wanted television, so it's gifted that. So these are all our partners, and I again want to just share one case. And this is was a child who referred to Dr. Lokesh at that time, and Dr. M.R. Lokesh, along with Dr. Mamta Manglani, has diagnosed this child as HIV positive, and this child was the mother was buying the drug, because that time the drugs were not available. So through NGO support, the child was supported. And if the child was not given the drug, the child could not survive till 34 years of age. This is a recent picture I have put, taken for the child, and he is following now in adult center. So you can see that the providing the drug is very, very essential, and providing the care is also very essential. And this is another child who has repeated PCP pneumonia at 3 years of age. And she was very lucky that in August 2005, the ART was started, and she got the ART on time. And she was also very poor background. And now she is 23 years old and going to college. So this is my team PCOE, and it's a teamwork. And thank you, Dr. Mamta Manglani madam, who has started this journey. I'm taking over now. Dr. Radha madam is supporting and guiding me for all throughout this journey. Thank you very much.
Thank you, Dr. Yashwant Gabale, for so beautifully nurturing the Pediatric Center of Excellence for HIV. Yes, the plant that Dr. Manglani madam has sown, and now you're nurturing it into a tree for the various innovations in HIV. Now we move to the next speaker. May I invite Dr. Sanjeevni Masaukar, additional professor in the Department of Pediatrics and in charge of PICU, to talk about research and publications in our department.
She's not joined.
Dr. Sanjeevni?
Arpita,
She'll
she's not
go
here.
to the cases, she can join and then.
Okay, sure. So
she's
we
there.
move ahead with the case.
Yeah.
And she's coming? Okay, she's here.
Yeah, she is here.
Okay. Can you please share your screen, Dr. Sanjeevni? We can see the screen.
Yeah.
You can begin and do the
Good
slideshow.
afternoon, everyone. Myself, Dr. Sanjeevni Masukar, Additional Professor, Department of Pediatrics, PICU in charge and Cardio. I thank IAP and our HOD, Dr. Radha ma'am, for giving me opportunity to present research and publications of our department.
Slide.
Yes, we can see it. Go ahead.
Yes. So we are lucky to have many doyens in pediatrics who have done important research, which was innovative, impactful, resource generative, rewarding, and help in development of the various subspecialties. We had total 50 original publications, case series, and 11 book chapters in last 5 years. It was a COVID time. And we have highlighted a few publications from all the specialties, that is early detection of glomerular dysfunction and renal tubulopathy in children with sickle cell disease, moya disease in adolescent with HIV-1. Then there is a diagnostic dilemma in era of genetic testing, congenital myopathy versus limb-girdle muscular dystrophy, rare cases of persistent hypocalcemia in infancy due to PTH gene mutation, follow-up case of rare case of adrenal insufficiency due to NNT mutation. Here, the early detection of glomerular dysfunction and renal tubulopathy in children, it's detected early using simple urine parameters and can be prevented with early and appropriate dosage of hydroxyurea with good compliance. Derangement in urine microalbumin correlated significantly with low mean hemoglobin less than 9 gram. In moya disease in adolescent HIV, it is due to medial fibrosis, intimal hypoplasia, loss of muscularis, and direct invasion by virus. And early initiation of ART plays important role in prevention of HIV vasculopathy. So maintaining good adherence to ART, thus achieving viral suppression, good immunity may help to prevent vascular complications. We have this case of diagnostic dilemma where the patient presented with both the features of myopathy and muscular dystrophy, and on genetic study, it was found to be having both the congenital myopathy and limb-girdle muscular dystrophy. There was interesting case of first reported case in Indian subcontinent, a rare case of adrenal insufficiency, where it was the levels, it was isolated glucocorticoid deficiency without mineralocorticoid deficiency, and it was due to familial glucocorticoid deficiency with homozygous mutation in NNT. The patient presented with repeated hypoglycemic convulsions. So it is needed that we should address those hypoglycemic convulsions and to prevent morbid sequelae, to do endocrine evaluation. Then there was a persistent hypocalcemia due to PTH, which was because of the isolated hypothyroidism, and it was a homozygous gene mutation. Then there are a few publications from the intensive care hyponatremia in children with tuberculous meningitis. Then there is acquired hemoglobinemia, sporadic holy disaster, intravenous max self-infusion as first-line therapy in control of spasm and muscular rigidity in childhood tetanus, causality, severity, and avoidability of drug reactions in hospitalized children, prospective cohort study. So here this publications provided insight in differentiating and treating various syndromes related to dysnatremia with TB patients having intracranial raise ICT hydrocaph. Intravenous Maxself also to prevent spasms as a first-line therapy helped to prevent mortality related to prolonged ventilation, sepsis, deep sedation. Acquired methemoglobinemia secondary to holy colors improved the awareness and prevented future disasters due to ban on using chemical colors in festivals. Adverse drug reactions in hospitalized patients, improved awareness and preventive measures to avoid harm due to drugs. There are important key publications from telemedicine and HIV. Can telemedicine initiative be effective intervention strategy for improving treatment compliance for HIV patient? Evidence on cost and improvement in treatment compliance from Maharashtra. So this study generated evidence on cost of pediatric ART delivery through telemedicine and linked this cost to the treatment compliances in India. And the 3 link centers, the average cost per visit was INR 1803, and as compared to non-link, it was less, 2 times less than the cost of the unlinked centers. Coming to the PHO publications, we had the Nestroff. Test which made aware of mass screening of patients with thalassemia trait in olden days and in resource poor settings. Then we had alloimmunization of children with SCD. The present study found that low prevalence of antibodies in patients with SCD, and thus patient presenting with symptoms in younger age receiving hydroxyurea and good compliance were having less allo antibodies. Then there is compound heterozygous delta beta thalassemia, has varied clinical features with severity ranging from non-transfusion dependent to transfusion dependent thalassemia, this hemolytic anemia. Then NRRTC publications, it was indigenously prepared, ready to use therapeutic food in children with severe acute malnutrition. And we had assessing the efficacy of low cost of indigenously prepared a soya-based ready-to-use therapeutic food with standard produce peanut-based ready-to-use therapeutic food, and then efficacy of ready-to-use therapeutic food in malnourished children with cancer. So this indigenously RUTF appeared to be superior to standard nutrition therapy in promoting weight gain in children with SAM. And SAM children need a safe, palatable food with macronutrients and micronutrients tailored to their needs in order to recover. So our study demonstrated the new soya-based formulation is comparable to peanut-based with respect to rate of weight gain and recovery rate. It was cheaper alternative and it can be used as alternative to RUTF in resource poor settings and patients with peanut allergy. Then the RUTF is efficacious in improving weight gain and nutritional status in children with cancer and decreases the treatment-related toxicities with cancer in undernourished children with cancer. Coming to the LD, this was the innovation which indigenous produced RUTF at our center. Coming to neurodevelopment and epilepsy, there was role of language in multilingual children with suspected dyslexia, a pilot study, which is the purpose of this study was to assess the language profiles and comorbidities in multilingual children with suspected dyslexia. And this dyslexia assessment of Language of India iLab assessment in 2 languages are able to differentiate children of limited English proficiency from suspected dyslexias and red flag signs, concern for learning or primary language disorder. Then intranasal midazolam IV injection preservative-free was found to be as safe and effective as diazepam when midazolam spray was unavailable. That was in 2005. The overall interval between the arrival at patient and cessation of seizure was shorter. The intranasal route can not only be used at center, but with appropriate instruction by the parents of the children with acute seizures at home. We had 11 book chapters in pediatrics and medicine books on various mentioned topics by all the faculty members. We have highlighted research projects for last 3 years. So study of academic profile of children presenting with learning disability in tertiary care center, endocrine impact of allogenic HSCT in children, retrospective study on acquired demyelinating diseases. So hospital-based sentinel surveillance for pneumococcus or other invasive bacterial disease phase 2. So these are our few research projects which are going on. Then we had this pediatric international nutrition study 3, prospective multicenter course study for nutritional practice outcome in PICU worldwide. On the age, under the aegis of Atable Research Foundation and DAFPAL Pediatric Alumni, we organized pediatric CME at LTMMC and outside on alternate year on interesting pediatric topics. We had Pediatric Clinic of India Journal. And coming to prizes, awards, grants, we've under the leadership of Dr. Yashwant Gabale, NRRTC, we got a Glenmark Nutrition Award in 2023, first prize. Also, there was IDECON conference. We got IDA President Award, second prize in MBCon, James Blunt Endowment Award. Then we got MUHS University prizes for publishing in journals with impact factor more than 2. Then UGC grant for travel, producing or presenting oral paper abroad. Then our student got American Association Pediatric Prize. Then our assistant professors, Dr. Neha Pandey, Dr. Savita Karsen, Dr. Sadhna Zope got prizes in presentation at various conferences, renal profile outline in children admitted with COVID infection at tertiary care, an infant with congenital nephrogenic diabetes insipidus with polyuria hypernatremia, thrombosis in case of nephrotic syndrome, and rare case of transplant renal artery stenosis. So I thank all this for giving us opportunity to do the research and to present it on this platform. Thank you.
Thank you, Dr. Sanjeevani Masavkar, for taking us through this huge umbrella of research in such a nutshell. Now we move on to the interesting cases. For that, I would like to invite Dr. Radhika Ramesh, a PG student from LTMMC, to begin with the first case.
Thank you, ma'am. I'm Dr. Radhika Ramesh, PG student at LTMG Science, and I'll be starting with the first interesting case presentation. Stiff start, is it a muscle? This is a 5-year-old male child born of third-degree consanguineous marriage, brought with the chief complaints of struggling to walk since 2 years, frequent falls since 2 years. On inquiry, the walk was difficult and was precipitated by prolonged sitting or in cold climate. Similarly, in the upper limbs, on holding objects, there was an abnormal tight grip. As you can see in this video, when we make the child sit for a prolonged duration, there is sustained stiffness and plantar flexion, leading to tiptoeing and gait abnormality. For these complaints for the last 2 years, the child had shown to various practitioners, and initially it was regarded as probably a nutritional deficiency or labeled as malingering or even an epilepsy syndrome. It was not evaluated completely. There was no history of progression of complaints, no history of limb weakness, no cranial nerve abnormalities, no history of sensory abnormalities like tingling or numbness, no history of any feeding or respiratory difficulty. This is a pedigree chart with our patient who is a 5-year-old child and an unaffected sibling. There is a complaint of similar such stiffness in the maternal aunt. However, we have not been able to get any further details. On examination in head to toe, we found that the child had hypertrophy of calf, biceps, triceps, trapezius, brachioradialis, and the deltoid. Gover sign was negative. In neurological examination, higher mental functions normal, cranial nerves were normal, the tone, power, and the reflexes were normal. There was no dysmorphism. As you can see in these images, the child had the typical Herculean body appearance with hypertrophy of the deltoids, the calf muscles. In view of complaints of struggling to walk, frequent falls, Herculean body appearance, and hypertrophy of muscles, with no muscle weakness until now, and having normalcy in between these episodes, we performed certain bedside tests to confirm the diagnosis of myotonia. As you can see in this video, we performed the percussion myotonia by striking over the thenar eminence, and you can see a sustained contraction with slow relaxation of the muscle. Similarly, on striking over the calf muscles, there is sustained relaxation and dimpling over the skin that you can notice. Here we have elicited grip myotonia, where on asking the child to either shake the hand or hold firmly, on releasing, there is sustained contraction with delayed relaxation. Investigations were done to confirm the diagnosis of myotonia. CPK levels were within normal limits. EMG and CV studies showed spontaneous myotonic discharges in the upper limb as well as the lower limb muscles and in the hand muscles, suggestive of generalized myotonia. To confirm this diagnosis, we sent a clinical exome, which has shown CLCN1 mutation, autosomal recessive, suggestive of myotonia congenita. Hence, we started the child on carbamazepine at 10 mg per kg per day. Doses were gradually increased as per response. There was mild improvement, around 25%, noticed in the symptoms. Physiotherapy exercises were continued and the patient was routinely followed up on OPD basis for assessing the improvement. In view of minimal response to carbamazepine, we will now consider switching the child to mexiletine as it has shown good response to chloride channel mutations. Now, I would like to invite Dr. Arpita Adhikari, pediatric neurologist and associate professor, to enlighten us on the approach to such cases.
Thank you so much, Dr. Radhika, for a wonderful case. Yes, I'm sure you all are wondering whether it's a muscle or so. So we've just taken a few flowcharts for which will be very useful to the postgraduates and the general pediatricians. An approach to a pediatric bodybuilder. So whenever, as this child had Herculean body appearance as one of his features in clinical examination, so when we have such a child with hypertrophy of the muscles, one is it can be either physiologic, where he's an adolescent and lot into strength training. Second is the classical pseudo hypertrophy, which we see in office practice, where the child has pseudo hypertrophy of calf muscles, which is mainly because of muscle dystrophies, that is DMD, BMD, metabolic myopathies. And if not that, then it could be true hypertrophy because of myotonia congenita or neuromyotonia. In pseudo hypertrophy, it is because of the fatty infiltration of the muscles, and in true hypertrophy, as in our case, it is because of excessive muscle hyperexcitability. Now going to the next flow chart, since our child had also presented with frequent falls. So as most of the pediatricians come across such events, and he was also misdiagnosed as malingering and epilepsy with many other at many other places before coming to us. So when a child comes with frequent falls, one is an entire spectrum of your cerebellar and non-cerebellar disorders, which I'll not deal into. But when he comes with such intermittent falls, which is leading to struggling to walk. So one thing is, as he was misdiagnosed as epilepsy, we should consider consciousness during the episode. And when asked if the consciousness is not preserved, it could be an atonic seizure. And then we go on to the gait. So what can lead to fall? It could be either loss of tone of muscles or excessive tone of muscles. So with the preserved consciousness, when there is excessive tone of muscles, which is persistent, then the child would be an hemiplegic or he would be a spastic gait. And if there is intermittent sustained contraction of a limb muscle, it could be dystonia. But in our case, it was only with some precipitating factors such as prolonged sitting during cold climate, and it only affected the initial part of the walking. And after that, once he started walking, he was completely normal. And dystonia, generally you get it when the child is already walking, he makes his limb into dystonia. But in this case, this is at the initiation of walking. So myotonia congenita is a non-dystrophic myopathy. It's very rare, 1 in 1 lakh children globally. It is a sodium or a chloride channelopathy. In our case, it was a chloride channelopathy. You get the typical Herculean bodybuilder appearance. Commonly, it presents as difficulty walking, feeding, clumsy gait, inability to release the hand grip. It is a mutation of CLCN1, and as I already said, excessive muscle hyperexcitability leads to the true hypertrophy of the muscles. The confirmatory test for diagnosis of myotonia, the bedside tests are extremely useful. That is a percussion myotonia and the grip myotonia, which Radhika beautifully showed in the videos. There is one warm-up phenomenon wherein you ask the child to clench and unclench the fist persistently for 5 to 10 times. And when the child keeps on doing that, the activity becomes better if it is myotonia congenita, and it worsens if it is paramyotonia. The EMG is a gold standard and it is very useful. You get a dive bomber sound, which I'm going to show you what it is. And genetic test is there to confirm the diagnosis. It can be controlled by many drugs. Why we need to know this condition? Because drugs are used in it and there is a very good response which helps the child to improve the activities of daily living. The drugs that are used that raise the depolarization threshold of muscle membranes, and these are carbamazepine, phenytoin, mexiletine. Muscle warming routines are considered. Specialized physiotherapy is given to children. This is the dye bomber sequence, meaning when you insert the needle while during the EMG, then there is a noise if you apply the headphone over there, which is like a dive bomber, the aircraft which were used during the World War. And this is due to the excessive amplitude and frequency and the discharges which are waxing and waning and ranging in between 20 to 80 hertz. So just to review the case, this is a case by Gene Review, which has also said that it is very rare and the prevalence is only 1 in 1 lakh. There was a case by a hospital of Bhubaneswar, with a hospital in Bhubaneswar, where a 14-year-old boy with similar complaints was treated with mexiletine and he had a wonderful response. This is another case where 2 brothers of myotonia congenita, they were detected with a novel mutation of CCLN1. Reviewing the medications, there are various studies. Some of them say that carbamazepine has got an effect. Some of them say phenytoin. We could not find a large study on the children with mexiletine, but we found an adult study on mexiletine, where it has said that mexiletine can be very safely used after doing an ECG and ruling out the long QT and the QRS, and mexiletine has wonderful response. So the key takeaway points from our case are that every abnormal posturing of the limb is not dystonia. Whenever there is an Herculean body appearance with history of intermittent falls when the child starts to walk. So the history is extremely important, and we all know as pediatricians that we need to take that fall is when. So when we digged into it, the father categorically said that it's only after prolonged sitting and when it is winter season, the muscle becomes stiff, and because of that, there is a fall. So that should be considered as myotonia congenita. Simple maneuvers for pediatricians like clenching and unclenching the fist and looking for the grip should be done in office practice when there is a clinical suspicion. Bedside clinical test, they are like amazing, the percussion and the grip myotonia as we have shown in the videos. EMG is a useful diagnostic tool to confirm myotonia, as I already told the bomber sequence. Genetic testing is there to confirm the diagnosis because there are sodium channel mutations and chloride channel mutations. Mixilitin works very well with the chloride channel mutations. Physiotherapy should be initiated, and carbamazepine, phenytoin, and mixilitin are the drugs that are approved by FDA, and they have a good response in myotonia. Thank you so much. These are the references. So may we move on to the next case? Yeah, so now I would like to invite our next case, the presenter, Dr. Avanti Sauji, again a PG student from LTMMC.
Good afternoon, everyone. I'm Avanti, and I'm presenting the second case for all of you today. I have been mentored for this by Dr. Savita Khadse ma'am. So we present a 7-year-old boy who was born out of a non-consanguineous marriage, birth and developmentally normal, with complaints of vomiting and fever since 2 days and 1 episode of convulsion on the day of admission. It was a generalized tonic-clonic type of convulsion lasting for about 2 to 3 minutes, and it resolved on its own. There were no other complaints like headache, neck pain, or altered sensorium, and nor were any focal neurological deficits noted. There was no previous history of any convulsion or any family history of seizures. So based on the history, we had differentials of meningitis and metabolic causes. We went ahead with the examination to find out that the blood sugar levels were pretty low at 40 milligrams per deciliter. The child was dehydrated, he was hypotensive, and he was thin-built. Other examination, including the central nervous system examination, was unremarkable. So we realized that we were dealing with hypoglycemic seizures. After the initial assessment as per the PALS protocol, the hypotension was initially treated with the fluid resuscitation. Since the child was hypoglycemic, after collecting the critical sample, we gave him a 10% dextrose bolus, and it was followed by a glucose infusion drip. We also saw that the child had generalized hyperpigmentation, as seen in these pictures, quite prominent on his face and on his palms. We went ahead with the basic investigations. The complete blood count was normal. However, he had severe hyponatremia and a normal potassium level. The critical sample confirmed our diagnosis of hypoglycemia, and we also noted 3+ ketones in his urine. The insulin and the growth hormone response was appropriate. However, serum cortisol levels were low. So in view of the symptomatic hyponatremia, a hypertonic saline bolus was given, and further endocrine evaluation was planned in suspicion of adrenal crisis. We saw that cortisol levels as well as aldosterone levels were low, and his ACTH was significantly raised, suggestive of an adrenal cause of this. The serum testosterone and 17-OHP levels were normal and helped us to rule out congenital adrenal hyperplasia. The USG of the abdomen was normal, tuberculosis workup was negative, and the thyroid function tests were normal. Other autoimmune workup has now been planned. There was no history given by the parents of any long-term drug use. There was no absence of tears, swallowing difficulty, or any long-term CNS complaint. So we came with this diagnosis of primary adrenal insufficiency with involvement of both glucocorticoid as well as mineralocorticoid pathways. We started the child on oral hydrocortisone and fludrocortisone. A genetic workup is now planned for etiological evaluation, and now the child follows up with us regularly in our endocrine OPD. This is his follow-up picture, and we can note the significant change in the hyperpigmentation. Now I request Dr. Savita ma'am, pediatric intensivist and pediatric endocrinologist, to carry forward with the discussion of this case.
Thank you, Avanti. So, to begin with approach of hypoglycemia in children. Definition of hypoglycemia is slightly controversial and lacks consensus, but recent guidelines of Pediatric Endocrine Society gives us a clear cutoff.
Mute one laptop because it's echoing. Avanti and
yeah. So definition of hypoglycemia is slightly controversial, and recent guidelines of Pediatric Endocrine Society gives us a clear cutoff, which says if the symptomatic patient is there, sugar less than 60 will be called hypoglycemia. For asymptomatic children, first 4 hours of life, any sugar less than 25, 4 hours to 24 hours of life, sugar less than 35, 24 hours to 48 hours, sugars less than 45. After second day of life, any sugar less than 60 will be called as hypoglycemia. A special note that children with type 1 diabetes mellitus, sugar less than 70 will be also called as hypoglycemia. Now, the symptomatology of hypoglycemia can be sympathetic symptoms or neuroglycopenic symptoms. Sympathetic symptoms in the form of tachycardia, tachypnea, anxiety, tremors, lethargy, or neuroglycopenic symptoms like convulsions, motor or sensory disturbances, visual disturbances will be there. Now, to classify etiology will be there is a slight delay from the presentation point of view. The presentation load नहीं हो रहा है. So after the symptomatology, the common etiology which has been proposed are either decreased substrate or increased demand of the substrate like glucose, or endocrine and metabolic disorders. I am restarting the So etiology will be either decreased substrate or decreased substrate, that is prolonged fasting in malnourished children or severe acute malnutrition children or premature children, increased demand because of sepsis, shock, renal failure or congestive cardiac failure, poisoning and intoxications, endocrine causes like adrenal insufficiency, primary, secondary or tertiary adrenal insufficiency, congenital hyperinsulinism, hypopituitarism or growth hormone deficiency. Metabolic causes like glycogen storage disorder, galactosemia, hereditary fructose intolerance, organic acidemias, or fatty acid oxidation defects. Now, to move on to a simplified approach of how to approach a child with hypoglycemia, we divide them into two categories based on serum ketone if possible, if not possible, urine ketones. If they show a large ketone that is more than 2+, we call them ketotic. If they show less than 2+ ketone, we call them non-ketotic or nil ketones. Now, ketotic children will be examined for hepatomegaly. If yes, they will come under a category of glycogen storage disorders. If there is no hepatomegaly, they can be growth hormone or cortisol deficiency or other metabolic disorders. If they are non-ketotic, that means after confirming that the ketone strips are not expired ones, if there are no ketones detected, we check the serum insulin. If serum insulin is not detectable, which is the normal response by the body, that means whenever there is hypoglycemia, body, to prevent further damage, switches off the serum insulin production. So if it is detectable, even a slight amount, it will be called as congenital hyperinsulinism. And if serum insulin is not detectable, it will be a fatty acid oxidation disorders. If all the above tests come normal, we call it idiopathic ketotic hypoglycemia, that is acceleration starvation ketoacidosis, which is seen in children more than 18 months of age and spontaneously resolved by 7 years of age. Next slide, please. So we now next we move on to the most important part of it, critical sample collection. So whenever we have a child who is presented to us with the predetermined cutoff that he is hypoglycemic, we have to go ahead with critical sample collection. Critical sample collection, to specify, you have to collect, critical sample collection has to be done of blood and urine at the time of hypoglycemia before the treatment is initiated for glucose, hormonal profile, and ketones to classify and divide further etiology. Mind you that to help the students of postgraduate students and general pediatricians, we have to collect 4 plain bulb and 1 urine container. 4 plain bulb, 1 is fluoride bulb, for confirmation that it is hypoglycemia, because glucometer reading can show plus or minus 10 to 15 milligram per deciliter variability. We have to collect a second bulb of plain bulb for hormonal profile, ketones, lactate, and electrolytes. Third bulb of EDTA for collecting complete blood count and sepsis profile. One heparinized bulb for venous blood gases and ammonia. And the urine sample has to be collected immediately after the stabilization of child for urine ketones, and if needed, further analysis of JCMS or a tandem mass spectroscopy. One more note here, that process the sample as fast as possible, because the glucose level will keep on dropping by 6 milligram per dl every hour of delay. Now, few words about the pediatric adrenal insufficiency. It's a very rare disorder. So 90 to 140 cases per million. Etiological classification, 75% or two-thirds of the cases turn out to be congenital adrenal hyperplasia. 95% of them will be 21 alpha hydroxylase deficiency. Remaining 15% cases turn out to be autoimmune disorder, where there are autoimmunity against the same enzyme 21 alpha hydroxylase, which doesn't allow the gland to produce adequate amount of cortisol, and remaining other disorders like adrenoleukodystrophy, AAA syndromes. Causes can be primary, that is where the adrenal failure is happening, or secondary, where pituitary is not able to secrete ACTH, or tertiary, where hypothalamus is not able to secrete the CRH. Symptoms can be very non-specific, like anorexia, weight loss, orthostatic hypotension, or they can directly come in severe shock. Examination findings are poor skin turgor, dehydration, skin hyperpigmentation. To emphasize this, because the ACTH has a melanocorticoid activity, melanocorticotropin activity, that's why there is a if there is a primary adrenal failure, ACTH increases and skin hyperpigmentation happens. They can present in hypotension or shock. Management of this condition involves starting them on glucocorticoid, mineralocorticoid. Glucocorticoid, that is tablet hydrocortisone, 10 to 12 mg per meter square per day into 3 divided doses. If it is not available at certain center, it may not be available. So giving tablet prednisolone, single OD dose. Mineralocorticoid, giving tablet fludrocortisone, 0.05 to 0.2 mg. No meter mg per kg. It is a single tablet. The tablet has to be divided into 2 equal doses and can be given. We always emphasize these children about the sick day regime. Now, what is sick day is during the sickness period, to define sickness, whenever they are not able to take orally adequate diet, that is a sick day. So sickness period, they have to double and triple the doses of glucocorticoid to cope up with that stress of illness for next 2 to 3 days. So now take home messages from our case. Hypoglycemia will be any patient who is having glucometer reading less than 60 milligram per dl. Most important step will be sending a critical sample. Most important investigation will be getting urine or serum ketones, looking for the clinical clues like hyperpigmentation, hepatomegaly, or short stature for etiological diagnosis, and any GIR requirement, that is glucose infusion rate requirement of more than 8 milligram per kg per minute, suspect congenital hyperinsulinism. These are our references. Thank you so much.
Thank you, Dr. Savita and Dr. Avanti, for a wonderful case. Now I hand over to Dr. Priya for the further proceedings. Thank you.
Thank you. Thank you so much. It's sharp 4 o'clock and you have completed all the presentations. Thank you so much for being on time completing. I now request our Jagdish Chinappa sir for your comments, suggestions, whatever, questions.
Yeah. Actually, being from Mumbai, I passed out from Grant Medical College, and we were always in awe of Sion Medical College, because at that time we had giants of pediatrics who were in Sion, and we had Dr. Athavale who had just retired, and Dr. Lokeshwar who was heading the department with Dr. Mamta Manglani, and I have in fact come there for the first training program on breast milk banking. Dr. Armida Fernandez, who was there with Dr. Jayashree Monkar. I think it has been one of the most iconic institutions because so many firsts have come out, and as I can see now, so many subspecialties have developed. I think after Wadia Children's Hospital, the next hospital which took up subspecialty training and progression was Sion Medical College. And today it has been a wonderful experience to see how this department has progressed, and such fantastic cases which have come out. And the real inspiration was the HIV unit, which has progressed so uniquely for so many years and delivered care across the state. So congratulations to this great department. And I fondly remember my classmate, Dr. Bakul Parikh, who was also from Sion Medical College, and Dr. Upendra, Dr. Yavle, Dr. Nitin Shah, and all the other presidents of the Indian Academy of Physiology. So back to you, Priya.
Thank you, sir. Yavle sir, any comments from your side after the presentations?
No, but I can only say that I have literally seen this department grow from a very small pediatric department to this level today. And I mean, nothing can be more rewarding to see your alma mater progress so much. And hats off to the visionary seniors and the professors that we had. And I mean, it's so rewarding. I'm so happy to be here on this platform today, witnessing the progress and the presentation that the fellow colleagues have made today. And thank you, Radha, for continuing the department's what should I say, legacy of great joints who have shaped them. And I cannot, it'll be incorrect if I don't name Jayashree's immense contribution in the development of the neonatal department. And mind you, she has been the dean of Sion Hospital also for a short period of time. And it was nice to hear from her that Department of Pediatrics was rated number 1 as one of the best performing departments in the institution. Thank you again, and it was really wonderful connecting with the old fellows from Sion Hospital. Thank you.
Thank you, sir. We are indeed very glad that you joined this session. Upendra sir, any more comments from your side after listening to the presentations?
No, perfect. So from Dr. Radha to Dr. Radhika. So LTMMC always rock. So the legacy is going to continue. And you can see Arpita, she was the gold medalist, MD. She topped the Mumbai University, but again came back to Sion. So that is how Sion, attracts wherever you go. So academicians are always attracted towards Sion. And as Dr. Radha very rightly said, that ours is the first institute when you enter Mumbai. So all departments have always, the workload is tremendous, phenomenal. So people are usually scared to take Sion. But look at this, what happens once you have so much of work. And we are all, as Dr. Vijay said, Vijay, myself, Bakul, Nitin, Rohit, we are all, in practice also, we always feel almost everything somewhere we have seen in Sion. So that is how the teachers have taught us the basics. Just now we saw the Herculean boy, the flowchart, which Arpita displayed. So this is all is required. I think science is getting finer, but we are continuing and then, training the UGPG so well. So that is how it continues. Thank you so much, Yashwant. That was wonderful. Your work on HIV speaks volumes. Of course, Jayashree set the ball rolling with Dr. Fernandez Madam in neonatology, and all the departments are doing great. Always proud to be a Sionite.
Thank you. Thank you, sir. Srinivasan sir, thank you so much for joining. Any comments from your side, sir? Srinivasan,
I've been regular this thing. 3 times I had gone as DNB examiner, and I have been very close to Madhuri Kulkarni and many others. So they were doing such a wonderful job and they very well presented cases. So I'm excited and nice to see all of them.
Thank you so much for joining, sir. Now we are awaiting for jogisms from our past president, Dr. Pramod Jog, sir, for your summary. Over to you, sir.
Oh, thank you, Priya. It was a great afternoon, and with Dr. Jayashree Monkar as the chief guest, and Upendra and Vijay telling their own memories. I was, really, really very happy to learn their love for the alma mater. And Sion Hospital, which is the busiest hospital in Mumbai, and I never knew that it has 20 lakh footfalls and 80,000 admissions in a year, and the first tertiary care, hospital for one entering into Mumbai from any direction. So it's a great thing. I was just talking with Vijay in the morning, and he also told me his fond memories of this college when he was doing the post-graduation. And Dr. Radha told us everything about the institute, and the one which got established in 1959 with Dr. V.B. Athole as the acting chief. And then so many firsts like the Human Milk Bank in Asia, the Thalassemia Daycare Center, the Bone Marrow Transplant Center in the public hospital, being recognized as the learning disability clinic for the government of Maharashtra and one of the 7 pediatric centers of excellence for HIV in the country of India, with 9 subspecialties and 5 fellowships of the MVHS. And Dr. Atholi Research Foundation, which was established by the alumni, with those 5 to 6 doyen past presidents of IAP, and also nurtured by Dr. Armida Fernandez, Dr. Madhuri Kulkarni, and Dr. Jayashree Monkar. So, of course, there are quite a few who have contributed to the success of this particular institute. And then we heard a lot from Dr. Yashwant Gabale today, who is the in charge of the HIV Center of Excellence. And he told us the journey of this pediatric HIV clinic from 1998 till date. And he told us how it progressed from the integrated pediatric HIV clinic, then the regional pediatric ART center, then the pediatric center of excellence. And what one should always try to remember from what he said, that so many things which a center can give to the children at large, like for example the age specific counseling, that adolescent mitwa session, a very apt name, it's like a friend for the adolescents with HIV, the nutritional support, that free antiretroviral therapy, then that free immunization, then the screening for the comorbids, and the telemedicine services, and the prevention of mother to child transmission, rehabilitating support and linkage with orphanages, and so much about the these medicines, particularly the NRTIs, the NNRTIs, and the protease inhibitors, the regimen for the antiretroviral therapy, and also the management of the infants born to HIV positive mothers. Particularly the telemedicine data, which he told was quite impressive, and also the orphan children's data. Also, along with that, he told us about the group counseling sessions, and which are catering for the adherence and the nutrition and the positive support, which is so much required for the adolescents. So I wish all the best. I must say all the yash for Yashwant. Okay, all the success for Yashwant. For the center, which started with Mamta. Mamta is, of course, love. Okay, so I must say that I wish all the best for this activity. And then Dr. Sanjeevani, told us, highlighted the impactful and the innovative research activities. In addition to those activities related to that early detection of glomerular dysfunction in children with sickle cell disease, and that moya in adolescent with HIV, what I thought most important was the indigenously prepared, ready-to-use therapeutic food for children with SAM, because that's a need for our children with severe acute malnutrition. And she highlighted so many research activities, all including those neurodevelopmental and epilepsy-related research activities. It also reminded me to renew my subscription of that Pediatric Clinics of India, the journal which I used to receive it from Dr. V.B. Athole when he was there. But of late, I think I need to renew that so that I will also have the old memories again. And then Dr. Radhika Ramesh, she told us the story of that 5-year-old male child with history of consanguinity and frequent falls after prolonged sitting, with that Herculean body, with that percussion myotonia and delayed grip release. And she told us about this case of myotonia congenita, which is a neuromuscular channelopathy. And though it's rare, maybe 1 in 1 lakh, managed with carbamazepine and mexiletine. And she told us the approach, Dr. Arpita told us the approach to this pediatric bodybuilders with true hypertrophy and the pseudo hypertrophy, approach to the frequent falls. And it was a very, very great experience, not for us as well as for the postgraduates. He also told us about the warm-up phenomenon and the EFT, showing that dive bombers sound, and related some facts to genetic testing. I remember one of the neurologists telling me in a meeting that when you get such a child, always try to shake hands with the mother. And if the mother doesn't release the grip, then you take it that it is also myotonia congenita, because it's autosomal dominant in some of these children. Okay. And then Avanti Sauji told us about hypoglycemia in the primary adrenal insufficiency. It was a great information from Savita about approach to hypoglycemia. So all in all, I think this was a great program, and I'm sure, in fact, the residents are fortunate, those who are working in this particular institute, because there's a huge workload. And we heard from our past presidents, Dr. Vijay and Upendra, that it's really the faculty which is taking keen interest in nurturing the postgraduates. And in words of Radha, who told us about this comprehensive and the holistic care for all with empathy and communication, I wish LTMMC, the initial two alphabets LT, though they stand for Lokmanya Tilak, I must say they are the ones where I would say long tradition. Let the long tradition of LTMMC live long. Thank you.
Thank you. Thank you so much, sir. Giving attention to each minute detail of everyone's presentations. That's jokeisms for all of you. Thank you so much, sir, for your crisp summarization with all your, the jokeism, what we say. Thank you. Thank you once again. Congratulations and thanks to Sion Hospital faculty and the postgraduates. I think we are fortunate to have your session in our Academics with Institution today. Congratulations to the PGs, Dr. Avanti and Dr. Radhika, very well presented with the videos, which were very useful for the postgraduates also. Thank you so much. Over to Vijay, sir. Sir, you want to say something?
Yeah, let me take this opportunity to invite each one of you for the annual scientific meet of our Dr. Athavale Research Foundation. This foundation we established in respect of late Dr. Athavale in year 1988, and every year we have been meeting and holding a CME. This time it is scheduled for to be held at Nasik on 17th November. So you need to come and witness the love and affection that all Sionites have for our alma mater. Thank you.
Thank you. Thank you so much for the open invite to all, sir. Thank you, sir. Just to remind, the next session is on November 15th. Due to elections, we are not having the next 2 Fridays, but we'll be back on November 15th with Pandit Jawaharlal Nehru Medical College from Raipur. So request all of you to join in on 15th November. I now request our West Zone Coordinator, Dr. Jitendra Gawane, to deliver the vote of thanks.
Yeah, thank you, Priya. First of all, I thank Dr. Jayashree Madam for accepting our request to be chief guest for today's session and inspiring us throughout these years. Dr. Radha Ma'am for heading this department, and we know that how difficult it is to head such a great department, and you have aptly done this and taking us through the overview of the department and how subspecialties have developed. You told us very well. I thank my friend Dr. Yashwant for delivering the keynote address and taking us through the journey of Center of Excellence of HIV. Sanjeevani ma'am for research, impactful research in your department, what is happening. You told us very rightfully, and that inspired many of the institute to take research in their departments as well. Radhika, you presented the case very well, aptly mentored by Arpita, and to take the case to the logical conclusion is what Sion is meant for. And Avanti, for your case of primary adrenal insufficiency, and Savita insisting for that critical sample, how not to miss that collection of that critical sample is very important. So thank you, everyone. I thank Dr. Nitin Shah sir, Manglani ma'am, Yevle sir, Kinzavdekar sir, and many more stalwarts and academicians from this institute for inspiring everyone in day-to-day life. I thank Central IIP President Dr. G.V. Basavaraj sir, incoming President Dr. V.K. sir, immediate past President UK sir, and JC sir for bringing out this concept of academic with institute. All our vice presidents and HSG sir, Yogesh Parikh sir, and Param sir for coordinating this program very well throughout and completing this 40th episode. I thank all the delegates and DIP as well for continuously providing us the backup support. And finally, last and not least, Dr. Priya ma'am. Every week, this is the 40th week, and we know that we are going to have 50th episode before concluding this year. So very passionately, she's doing this, and she's a taskmaster, and every time she sits on our head to complete all the formalities like taking flyers and all those things. So thank you, Priya, and it will be remembered forever. And let's hope that this comes out as a coffee table book or something like that after the completion of 50th episode. So thank you, everyone. We enjoyed this session.
Thank you. Yes,
I forgot.
definitely.
Sorry, sir.
One more task is remaining to send the details, which has to be sent.
Yeah. So thank you, Pramod Jog sir, for every time giving us your jogism. Thank you.
Thank you.
Thank you all.
Thank you. Thank you so much, ma'am.
Thank you.
Good evening.
Thank you, everyone.
Thank you.
Bye-bye.
Jayashree, ma'am,
Thank you.
thank you so much, ma'am. Thank you.
Thank you, everyone.
Radha, ma'am, thank you.
Yes.
Thank you so
My
much.
pleasure. Our
And
pleasure.
congratulations. And we were fortunate to have the whole department's presentation. Thank you, ma'am.
Thank you. Thank you so much.
And sorry, Arpita, for troubling you so many times. Huh?
Sir, my pleasure. I learned a lot. Thank you so much for that.
So each episode takes this much efforts, actually.
I can
Thank you.
understand that, sir. Thank you.
Thank you.
And one
Thank you so much.
document is remaining from your side, so please send that.
What document?
For the coffee table book, ma'am. About what
Okay.
Yeah.
Okay.
Thank
Sure.
you. Thank you,
Thank you.
ma'am.
Thank you.
Thank you. Thank you so much. Bye-bye.
Shweta, thank you so much.